All right. And without further ado, patient-centered care, delivering survivorship care in North Carolina with Dr. Deb Mayer. Thank you so much for being here today. Let's find out a little bit more about you. PhD, RN, AOCN, FAAN, advanced practice oncology nurse who has consulted with organizations on issues to improve cancer care and has over 40 years of cancer nursing experience, nursing practice, education, research, and management experience. We do hear, I believe that's the dog we're hearing, is unmuted, Benny. Could you help us out and mute him, please? That's the dog. Perfect. Thank you so much. Dr. Mayer is past president of Oncology Nursing Society and was a member of the National Cancer Institute's National Cancer Advisory Board and Board of Scientific Advisors. All right, Dr. Mayer, welcome. Thank you so much for being here. Let me show you our first poll everywhere question. Many cancer survivors fear that the cancer will come back. True or false, A or B? We try to make this first question kind of a softball, so you can be thinking about that. And while you are, I'll say this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Deborah Mayer, PhD, RN, AOCN, FAAN, has no financial relationships with commercial interests as defined by the ACCME. All right, Dr. Mayer, we seem to have a theme going on. We have a super smart audience, and as always, they're right on target, I think. Would you agree that that's the answer you were looking for there?
Absolutely, absolutely.
Great, great. So we'll look forward to more participation on those polls. And without further ado, delivering survivorship care in North Carolina.
Thank you. And although I can't see all of you in the audience, I recognize many names. And I just want to say, if you've heard me speak about this before, hopefully repetition helps it sink in a little bit more. But I do update and revise every time to reflect the latest data that we have and to present different angles of this. And as many of you know, I love using these images from Lilly Oncology on Canvas, which is a collaborative with the National Coalition of Cancer Survivorship. Every 2 years, they have a contest with survivors, caregivers, and clinicians submitting artwork. And I think it helps bring the point home that a picture's worth 1,000 words. And then we know that survivors experiences that when life is back together again, it has changed. And we're going to talk about those changes and what we might be able to do to sort of ameliorate or mitigate them. Thank you. And there's nothing that's relevant as far as disclosures. Next slide. And what I'm going to do is talk about these different areas about cancer trends, because I always think it's helpful to know and put things in perspective. For myself, it's like in oncology, everything's cancer till proven otherwise, but in fact, there's other things going on in the world, and COVID is a good example of that. Talk about what survivorship is, talk about the unmet needs of survivors, focus a little bit on health promotion because it's an area that is not necessarily addressed as much or as well as it should be, and talk a little bit about how, when, where, and who will be delivering care models. So I just want to remind you, at the turn of the last century, cancer wasn't as big of a deal because people did not live as long. They would die of the flu or tuberculosis or GI infections, but we've made so much progress in these other areas. You can see that we're competing with cancer and heart disease as the leading cause of deaths for most people, with smaller numbers in these other areas. So this is just another example of that. We've made a lot of improvement in heart disease, but if you remember that cancer is a disease of aging, and I, along with other baby boomers, are increasing this number of people diagnosed with cancer, is because cancer is a disease of aging and there's a large cohort of people coming through. And that's probably going to go on for 10, 20, even up to 40 years from now until the boomers start declining. But the actual rates of cancer per 100,000 are not going up. It's just that there's so many of us out there. And this is another example that states where heart disease was the leading cause of death in 2000 and in 2014 are green. And it was heart disease in 2000 and cancer in the dark blue states. And every year more states turn dark blue. So cancer is surpassing heart disease for the reasons I mentioned. And in fact, in North Carolina, cancer has been the leading cause of death over heart disease for the last couple of years. Next slide. But just to show you, this is the new cases is not going up when you look at the rates of cases. And we're expecting close to 2 million people being diagnosed. But the number of deaths is declining dramatically over time. And you can see even over the last 10 years the progress we've made. What that means then is we're not preventing cancer from developing, although we're doing that in other areas. But of the people who have cancer, fewer people are dying of it, which means we're having an increased number of people who are cancer survivors. Next slide. What is hard to show the public is how many lives are actually saved because of this. And the American Cancer Society has created this from the statistics to show you what it would have looked like had we not made the progress we've made so far. And the blue line shows you the number of deaths that have been averted. The red line is the numbers that we would have expected. Next slide. But what that means then is the number of survivors is growing exponentially. And what really impresses me is we've known this since the mid-2000s. And talking about the numbers increasing hasn't really changed how you practice at all. And I think that's going to be the biggest challenge. And I'm going to ask you to listen to everything I say to think about if your numbers of people you're seeing doubles or triples, can you deliver the care you deliver in the same way or expect to get the care you received in the same way when the number of people is increasing so much? And the blue line, the blue color at the bottom is those under 50. And although we know that adolescent and young adults have cancer and childhood cancers, those numbers aren't growing to the same degree as older people. And I'm in the green group. Some of you may be in the purple or the blue or the red, but you can see the green and the purple, which is the 65 to 85 group, is really increasing. And you can see the numbers are going to increase dramatically to over 26 million. That represents about 5% of the US population. But most importantly, that means that about 73% of survivors will be 65 or older, which means that dealing with older cancer survivors is going to become the norm and compounds the issues from the cancer with the other issues we face as we age. But that big number of almost 17 million patients or survivors is not a one-size-fits-all. And if that's one of the take-home messages you get is people living with cancer, it is not a one-size-fits-all. The highest volume are people who've survived breast, prostate, and colorectal cancers. And that's the high volume. So you know when you see October as Breast Cancer Awareness Month or March for colorectal cancers, there's a lot of us out there. However, some of the other cancers have more complex needs related to the cancer and its treatment. And lung cancer and head and neck cancers are two of those where we can anticipate, even though the numbers are small, their needs are high. The other I wanted to show you is how many long-term survivors we have. And many of the research studies that are done in survivorship are for people who have survived less than 5 years. But that means that we're not studying the people who are out there. And if you look, 45% have survived for at least 10 or more years. We have very little research done on late and long-term effects of long-term survivors. We know that cancer survivors are at higher risk for developing a second cancer, and that's about 20% of all new cancers in a year are people who've had a previous cancer. So that influences the cancer history you take from them, especially understanding what their previous cancer was and what their treatment was and how that went for them, because they bring that into the room with the new cancer as well. Now this is North Carolina, so this is bringing it home. So if you look at the left state map, these are the counties. This is who's getting cancer, and this is the most recent data. We're always lagging behind a couple of years to get complete data on these things. So this is 2012 to 2016, and the highest rates are in the purple maps, the deep purple, as far as incidence. We're expecting in this year to get close to 60,000 new diagnoses this year, not counting skin cancers that are other than melanoma, like squamous or basal cell. The right map is, I'm sorry, I nodded too soon. Can we go back one? Great. The right map is mortality rates, and you can see they don't always mirror each other. So more people are dying in other counties than those who are being diagnosed. But in 2020, there's close to 500,000 people living in North Carolina who's a cancer survivor. Next slide, thanks. So I'm going to get into a little bit about the definition of survivorship, and that's been a little bit controversial. The reason being, in the next slide, what we did in the National Cancer Institute is we updated the definition of cancer survivor. While it didn't change as far as anybody diagnosed with cancer is considered a survivor from the time of diagnosis through the balance of his or her life, we have modified it to say there are many types of survivors, including those living with cancer and those free of cancer. People living with metastatic disease felt very much left out of this definition, and we did a whole survey of advocates, survivors, professionals, and what have you to do this revision. It's not meant to capture, it's meant to capture a population. It is not meant to label people. So some people are not comfortable with the term survivor, do not consider themselves a survivor, or think it's down the road that they consider themselves a survivor. That's up to the individual. What I'm talking about is the population management of people who have been diagnosed with cancer. Next slide. So the types of survivors are those who are living cancer-free, which is good news, and they do well for the rest of their life. That's about 10% of the population of cancer survivors who have no problems and go on about their life. The other groups include those who might have some treatment-related complications, whether it's residual peripheral neuropathies, lymphedema, some cognitive issues, whatever, but they're managing. And then those who develop a late recurrence, and those may be 15 or 20 years after the initial cancer. We see that more in breast and melanoma patients, but that can happen. And when we're treating patients now, we may be altering the actual natural course of the disease. So we may be seeing more of that as well. And the other is that they may develop another cancer. As I mentioned, about 20% of new cancers are in somebody with a previous history. Then there's those who live with their cancer. And those patients may have intermittent remissions and recurrences, so ovarian cancers and head and neck cancers, and lymphoma patients, lymphoma patients are two cancers that may be intermittently in remission and out of remission, and that can go on for long periods of time. And so it's always sort of waiting for the shoe to drop. And then there's those who never go into complete remission and have no evidence of disease, but with our newer therapies may be able to live for years. And that group is really understudied and underserved, those living with metastatic disease. If you think about the first years for diagnosis and treatment, and the last year is around end of life, many of these types of survivors can live for years in between, and we don't really address what that's like for them or research them in the same way. And I think that's a very underserved population. Next slide. So I just want to remind you of what survivorship means for the general definition. Could be anybody who's lived through a potentially deadly or life-altering event, whether it was a hurricane that came through here or flooding or a disease or a trauma of any sort. It's a dynamic process, so it changes over time. I was diagnosed in 2007, and those first couple of years after, that diagnosis for me was front and center. But now I'm this far out and I've been doing relatively well, I don't really think about it in quite the same way or as often. So it does change over time. It involves uncertainty because nobody can predict how this is going to play out or what the impact is going to be. And think about people with COVID, those who are sick with it, those who go into the hospital and may come out, and then what that means for residual impairment afterwards. So we really don't know what like lung function is going to be in somebody who's been ventilated with COVID after a while. We're going to need to follow these people over time. So that's the uncertainty about this. It's also considered a life-changing experience. It changes you, and it's very hard to have a diagnosis of cancer and not be changed in some way. It may be subtle, or it may be really obvious, but and it may take time for that to unfold. And it usually has both positive and negative experiences. So even with COVID, we're saying the nice thing about being homebound is our lives have gotten simpler, which is a positive aspect. The negative aspects may be we didn't train to be homeschool teachers for our children, or the issues of staying housebound for a long period of time. So many of these things have both positive and negative aspects. And then the other is that it's an individual experience with universality, because what I've gone through is not the same thing what you've gone through as to who I am as a person and what I bring to the cancer experience. And so they may have had previous history of trauma, they may have previous history of cancer, or their grandparents or parents may have had cancer. And so they're bringing that all into the room. And that's important to understand. One of the questions I encourage my students to ask is, when they talk to people with cancer, is ask them how it has changed their life. And you get a sense of who they are and what they've gone through at this point in time. And I think it's like seeing a patient's picture before they were diagnosed to see what they look like and what was important to them as far as family or what have you, to see the person who's sitting in front of you at the same time. Next slide. So the next question is, a person cannot be called a cancer survivor if they still have cancer after treatment has ended.
And we want to say again, thank you to all of those who are responding, and that's really phenomenal, and these are anonymous. So. Dr. Mayer, I see a trend again. How are they doing?
This is great, and that's true. Again, people get confused about this, or they'll say, well, I don't consider myself a survivor because I'm still on treatment. Again, that's okay for that person, but when you think about survivorship issues, you really need to think about time of diagnosis onward. An example is, we have come to the point when somebody gets hospitalized, the first thing we start talking about is when they might be going home and what do we need to do between here and there to help them in that transition. When somebody's diagnosed with cancer, we need to think about what we can do to prevent or minimize some of the experiences that they may go through to make it easier for when they are off of treatment, if they're lucky to have treatment ending. So for example, there's more research going on right now about being physically active during treatment as a way to mitigate some of the fatigue and maybe even some peripheral neuropathies. That being physically active and walking and doing things while getting treatment may help minimize fatigue, and also may help minimize peripheral neuropathies. And so I think we need to start thinking about, when treatment is being planned, are there things we should be thinking about that may help downstream? And certainly in other populations like AYA populations, we need to be thinking about things like fertility, which needs to be addressed before treatment starts. So that's why it needs to cover the whole span from time of diagnosis on. Thank you, and great responses. Now, you may feel like that doesn't work for you, but that's your choice, but that's where we are. The other thing that this model shows, it's not just for research, is when we think about the survivor's experience, the aspects of survivorship care include surveillance for long-term and late physical effects, new cancers, psychosocial effects. We know that in the last 10 or 20 years, with the advent of these newer therapies, financial toxicity has become significant. So we need to think about the economic effects, whether it's out-of-pocket expenses, insurance, other co-costs that may occur because of the cancer, ability to continue working. Even if somebody's over 65, we can't assume they're all retired. Thinking about the chronic conditions somebody may have, we know that on average survivors have 5 comorbid conditions, and that will go to the issue of care coordination because we do not manage those for the patients. They may influence the cancer treatment experience and vice versa, and so we really need to think about that. And I'm going to focus more on health promotion today because that's something that doesn't get as well addressed during and after treatment as it needs to be. And then again, the usual surveillance for recurrences or new cancers. Next slide. Thank you. So the seminal book, From Cancer Patient to Cancer Survivor, was done in 2006, and it did identify components of survivorship care, which I've just identified. And care coordination is going to be another aspect we're going to spend more time on. There was also a workshop done last year that looked at 10 years, well, beyond 10 years after this report to see what progress we've made. And while we've made progress in some areas, we've not made a lot of progress in some of the other areas. Next slide. I'm going to now talk about unmet needs of survivors, and this is called Bumps on the Road to Life. And many of the survivors' artwork have similar analogies of going from darkness to light. But not everybody does get all the way to the sunshine, and not everybody ends therapy. So we really need to be sensitive to where they are on their journey. Next slide. So I just wanted to give you a couple of summary slides that looked at a number of studies. And the question we answered correctly at the beginning of this presentation was that fear of recurrence is a very big issue. And I want to talk about a model that I use with patients that find it very helpful. That is the illness in foreground and background, so that the fear of recurrence is more prominent in the early days after cancer treatment, but it never really goes away. It may diminish, but as soon as somebody comes back in for treatment, whether it's to get a mammogram or another blood test or whatever, or walking through the doors of where they've been treated, that all comes back. And it's sort of like when somebody has diabetes, when they're in the hospital, they're being seen as a diabetic patient. But when they're out in the world, they're seen as Joe Smith, who does all these things, who happens to have diabetes. And so that illness in the background is when you're out living your life. My analogy with patients who seem to like this is that cancer's in the front seat in the car, and they take away your GPS and they tell you where to drive. When treatment's over, it's in the back seat, but you can still see it in the rearview mirror. And over time, it gets out of the car, and you can see it as sort of a speck in the horizon in the back. But when you walk in for your next test, it's back in the front seat. And so I counsel people that that's not the best time to make major decisions the week before a big test, or that you're coming in to see how you're doing, because naturally, even in the background, it's going to be there worrying about what you're going to find out. The other is that many people do not feel they're as well informed as they need to be or would like to be. And fatigue is the #1 long-term effect of having cancer and its treatment. We also know that that impairs functional ability, and that the greater unmet needs were in people who were younger, I like this, younger, less than 65, who also experienced anxiety, had poor quality of life, had comorbidities or ongoing symptoms. And so people with any of those issues are ones that maybe we should be asking more questions about. Next slide. And this is another example of that kind of data. So basically, if you look down that whole list of physical, psychosocial, or supportive care needs, about 1/3 of survivors have unmet needs related to either not being able to do things, worrying about the cancer coming back, or being more anxious or uncertain, worrying about their relationships, feeling like they have enough information. The issue is how to identify that 1/3 of patients, my apologies, That third of patients versus the two-thirds of patients who are doing okay in those areas. And so we really need to be doing better screening for those things. And again, those who have anxiety, depression, poor quality of life, are younger or have more advanced cancers, may have more unmet needs. And so we really need to think about how we screen people when they're back for visits to identify those who may be having those issues. Next slide, please. Thank you. So this is another example of by different cancers and by time since diagnosis. So this is 1, 3, and 5 years after for prostate, colorectal, or prostate. And the reason I'm showing you these, although it's a busy slide, is that when you think about survivors, they may have fears about like cancer coming back, have trouble sleeping, have trouble concentrating, and always feeling tired. When you look at, there's differences by type of cancer, but there's not as much variation over time. So you may think somebody's coming back 5 years later just to get their mammogram and a checkup and get the blessings that they look fine and they're good. It doesn't mean that they don't have these kinds of concerns. And so regardless of time since diagnosis, we really need to be asking questions so we can identify those who may need different types of interventions. Next slide. And this is very similar, and I'm just going to speed up through that. Basically, we know that some people have significant depression and anxiety. We need to be able to be screening for those to make sure that we can intervene with those. Next slide. Next slide, please. So I'm going to talk, keep going. Next slide. On the importance of patient-centered communication. This was a model that was developed over 10 years ago and is really important because each component of these patient-centered communication areas can change health outcomes, either more positively or more negatively, because patients are looking to us when we talk with them about getting information, responding to our feelings, managing uncertainty, enabling them to self-manage, because most of the care happens at home by the patient and their family or survivor, fostering relationships and making decisions. Next slide. But we're better at some of these things than others. So exchanging information, if you look at the blue and red, we're better at exchanging information, we're better at helping people manage and fostering relationships. We're less good at responding to emotions and managing uncertainty. And that wouldn't take a lot to do, is to acknowledge or elicit how people are feeling about those areas, because those are important components of the communication that we do. Next slide. And this next slide is another slide that shows that patients come away understanding what their follow-up care is. They're coming back in 3 months, they're going to have a scan or blood work. So we do a pretty good job about that. But look at the third column, the emotional and social needs. We do less well with that than almost anything else. And we do better with long-term and late effects management than we do with lifestyle recommendations, which is why I'm going to focus some on health promotion. Next slide. And this is another study that looked at a number of solid tumor patients across 3 different health systems. And again, they felt like they got enough information about surveillance, a little less about late and long-term effects. And again, look at that. The emotional and social needs is much lower. And again, less than half are getting treatment summaries, which is something that's been promoted for a number of years now. And it didn't matter what type of cancer they had as to their answers to this. Next slide. This is what they have said they would have liked more information about. Diet and lifestyle. A classic question when treatment ends is, okay, now what should I be doing to live a healthier life or to help be better so that the cancer doesn't come back? And that includes things like physical activity and exercise. There's a difference between physical activity and sedentary behavior. I don't know about you, but I feel like I'm getting COVID butt from sitting around so much, even though my weight hasn't changed very much, and that's because of the increase in sedentary behavior, even though I'm trying to get my steps in, etc. Issues about financial issues, the costs of prescriptions. We should know what the costs are for the drugs that we prescribe. whether they are working or want to return to work. We do a lot for children with cancer about not losing ground in school or talking to their teachers and classmates. We do nothing like that for people who are still working. Pain management, information about support groups, physical aspects, and psychosocial aspects. So they want more information about these kind of things. Next slide. So here's another question for you. Which one of the following is not a component of patient-centered communication?
All right, and if you're doing this by text, you would, exchanging information, you would submit A, managing uncertainty, B, conduct distress screening, that's distress screening, C, fostering self-management, D, or responding to emotions, E. All
Well, looks
right.
like most of you got it correct, which is C. Distress screening is an important thing to be doing, but it's not necessarily a specific area of patient-centered communication. It's actually being able to do an assessment to see if they're having distress, into what areas it is. So it's important, but it's not part of the model of patient-centered communication. Again, responding to emotions and managing uncertainty are important parts of this, but are often unaddressed. Next slide. Okay, so I'm going to spend a few minutes on health promotion because, again, I think this is one of the areas that we don't do as well with as we do in some of the other areas. Next slide. So just to make you feel better about yourself, this is not cancer survivors. This is the U.S. population. As you can see, only about 8% of us practice all the healthy behaviors that are recommended to us for healthy living, which is being physically active, eating enough fruits and vegetables, limiting alcohol intake, not using tobacco, and getting enough sleep. In fact, it's really appalling to see some of the numbers of where we're at. And the darker the number, the more they do those things, but even those groups don't get higher than 12%. So we have a long way in the general public, but at least with cancer survivors, we can help them facilitate this for themselves. Next slide. So as you can see here, very few people do all those things, about 10%. Only about 10% do none of those things, meaning that they smoke, they're not physically active, they drink, etc. Most of us are in between those things, where we probably don't smoke, but we may not be doing and we may not have much alcohol intake, or we may be physically active, but there's some of those we do and some of those we don't do. And that's true for cancer survivors as well. And I'm going to talk to you about why that matters, to pay attention to all of these behaviors, not just some of them. And this is for cancer survivors, but the general population looks like this as well. So most people are pretty good about not smoking. Many of them try to be physically active and try to limit alcohol intake, but they still have low adherence to fruits and vegetables. Next slide. The reason this matters is because it actually can improve your life, how long you live. And so if you're not used to hazard ratios, you see where the dotted line is over 1, that's basically the neutral position. Anything to the right of it means it increases your odds of dying. So alcohol use is the only one on the right side. So the more alcohol use you have, and then on the left-hand side is healthy eating, healthy weight, being physically active, and smoking. And the ones in parentheses, the smoking and the healthy eating, are the ones that are significantly improve your chance of living longer. And as you see, the hazard ratio goes from 1. If you do anywhere between 3 and 5 of these, you can actually improve your risks from dying dramatically. So it's not just a nice thing to do and it will make you feel better, but it actually can improve your outcomes as well. Next slide. So this is physical activity, and there's been a lot of research, and it's a busy slide, but the top half of this is about where there's strong evidence to show that physical activity prevents cancers and improves cancer-specific survival. And you can see how many are here. Breast and colon cancer and prostate cancer, especially if you do it afterwards, can improve your survival. And this is an important thing to tell people. And the sedentary time is really important for endometrial, colon, lung, and liver cancers. And then there's some evidence to say it also reduces anxiety, depression, fatigue, improves quality of life, improves physical function, and it doesn't make lymphedema worse, which for a while was one of the things we used to say to people, but there's been studies to disprove that. May improve sleep and bone health, and we don't have enough data on some of the things on the right-hand quality. If this were a drug and an oral pill, it would be really, really expensive. And I don't know that I have put it in here, but there's a great slide of 2 signs at like a pharmacy, which is living healthier and being physically active, or take a pill, and the lines in the take a pill. Our society is like, take a pill to make it better. But if we can show this evidence to people we're working with, it may give them some motivation to think about increasing their physical activity. Next slide. This is just the data on who's had those kind of conversations. So for lung and colon cancer patients greater than 5 years out, we're starting to get better about physical activity. It's nowhere near where it needs to be. A little less well on diet, not only how much and what kind. And 1 out of 4 survivors said that they had no discussion about any healthy lifestyle. And in another larger group of older patients who are at least a year from diagnosis, it's very similar findings. Importantly, 1/3 of the people who are obese or overweight did not have their weight discussed with them. So we're not addressing that when we should be. And in addition, 85% of smokers were recommended to have smoking cessation and had that discussion. So we've done a lot around smoking cessation, but we have not started doing what we need to do around healthy weight, diet, and exercise. Next slide. So the reasons that that doesn't happen, but we need to change this, is the oncologists who were surveyed felt they're too busy worrying about the cancer to think about these other things. Time pressure for number of visits and time allotted, and do not feel that they have expertise in behavior change. And that's okay. You don't need to be an expert in behavior change. You just need to be asking the initial questions and then hooking up people with the services that might be available to them, whether it's a cancer transitions program or Live Strong at the Y or other kinds of things that will address that. The other is that there's too much care coordination and concerns. This was a funny finding in this study. They were concerned if you address some of these issues, patients might be less adherent to whatever ongoing treatment that they were on, which is a funny finding, I think, because this is an important aspect of their care as well. So knowing this is even more reasons why we should go back into our practices tomorrow and think about how do we do this for people, even if it's providing them with some materials or a handout about available programs would be a step in the right direction. Next slide. Okay, here's another one.
All right.
Physical activity should be initiated once the patient has no evidence of disease.
And for those of you using texting, you would put A for true and B for false.
Great. It looks like most of you are getting in the right area, which is it's false, because we may see benefits even if it's started during treatment. And not everybody is lucky enough to have no evidence of disease, and therefore this is as relevant for people who are living with their cancer as those who have no evidence of disease. Next slide. So now I'm going to spend a few minutes on care models, because the question is how best to take care of these people, who should see them, how they should see them, when and where they should see them. And I'm just going to give you the headlines for this. Is there's not enough research to tell us if there's one approach that's better than another and for which populations. Next slide. So the reason this matters is because after the first year of treatment and before the last year of end of life, most of cancer care is actually at the middle part, but most of our efforts are focused on those 2 years at the beginning and end of this. And so it's both the largest volume of visits, and it's also the most costly part of care. And yet we spend little time thinking about how we deliver it, where we deliver it, and who delivers it. And I think that we need to start asking different questions. And so you can see that this is very expensive, and it also takes up high volume. Now, I think with COVID, we're seeing some changes. Many of us have moved to doing our follow-up visits through telehealth when that's possible. And all of a sudden, the crush in the clinic of having double and triple booked patients has been alleviated, because the only people you're really seeing are those who are being diagnosed or those who are under active care. And so we may need to rethink how we're delivering follow-up care, especially in light of how we're doing it with COVID. That doesn't mean to say everybody is appropriate for telehealth visits. And so I think we need to do more work to differentiate those who still need to come in for a face-to-face visit versus those who will most likely benefit from that kind of surveillance. Next slide. So there's many different kinds of adult follow-up models that have been described. Multidisciplinary is when you have a bunch of different professional groups in the clinic to see the single patient coming through. You know, MD Anderson and Memorial Sloan Kettering, who see 25 to 30,000 new patients a year and have a huge follow-up, they probably had the volume to sustain some of that. Most places do not for adults. Now, they may for childhood survivors or what have you, but it's a very expensive way to do it unless you have a lot of patients. Disease specific, I personally believe that if you work in a disease specific clinic, that's a good way to think about how you deliver your follow-up care, which is survivorship care, and how do you embed that and transition patients from this intensive treatment follow-up to more of a survivorship-oriented follow-up visit. And patients want to be seen and treated by their team. It may be, though, that they transition more to seeing an APP over time or others. A consultative service where somebody may come in one time to say, how do I manage this, or who should I be seeing for that? Some places set up clinics that are just consultative, and you see a patient once, deliver their care plan, review all this, and that's it. An integrated care model is sort of what I was talking about with the disease specific. If you're in a community practice or a general practice where you're seeing multiple types of patients, you're just integrating the follow-up to address survivorship issues as you go. And that's also making sure that the primary care provider is included in this. The reason that matters is who's going to be managing all those comorbid conditions with you. And although we may think we're doing patients a favor by writing for their high blood pressure medicine or what have you, we're actually taking them out of the loop of seeing their primary care provider who they need to be seeing for all that. The other is that if they don't have one, at the time of diagnosis, we should be doing what we can to get them hooked up with somebody who will follow and help manage them not only during treatment but afterwards. And then one we're doing research on is a risk stratified and shared care model, which means that there are certain groups of patients who are considered high risk. Think about bone marrow transplant patients or those who have a lot of complicated therapies or are at high risk for recurrence. They may need to stay within the cancer setting for longer term follow-up, whereas those who, like I pointed out earlier, the low risk, high volume patients in breast and prostate and colon cancer may do fine being seen by their primary care provider and being instructed as to what they need for surveillance testing. And shared care is when we're seeing the patient along with the primary care provider, and over time, the oncologist declines over time and the primary care provider increases over time, so that eventually they're just seeing their primary care provider. So there's not been enough research. That's okay, you can go to the next slide. But most models look at something that, this is a risk stratified approach of looking at low risk, intermediate, and high risk. And the UK has implemented this and looked at outcomes. And they really are pretty impressive as to how they've managed this and depend a lot on self-management by the patient, but they support that. Australia is trying to do that, but again, it's in the implementation phase, and we're trying to do research with that to identify those patients who may do very well in the low-risk group to figure out what that care would look like. Next slide. Now, that's all good from our end, but what patients are saying they want is they want a roadmap from the time of diagnosis as to what's going to happen. And we may be pretty good about giving them a calendar about their treatment. You know, you're going to get 6 cycles of this every 2 weeks, and then we're going to see you here and get this test. But we don't do it a lot for what happens afterwards, and that's what the survivorship care plan is supposed to be doing. But in this, this focus group with survivors, what they said is they want the fact that they're going to transition back to their primary care provider, even if it's years away, introduced and then revisited periodically. And they want to know when this is happening. They want to be reminded with the roadmap. And that they found in this study that the relationship with the primary care provider had the most influence on their transition readiness. In other words, if they had a good relationship with their primary care provider and they had this map laid out and reminded periodically of when they're doing this, that was the best way to do these transitions. And I don't think we do as good a job as we should be about mapping that out. And when I saw patients for breast cancer and did that, the first time I met them, I gave them their care plan, but I reminded them we were going to follow them up to 5 years and then be seen by their primary care provider. And every year I saw them, I would remind them, now it's 4 years, now it's 3 years, and don't forget next year you're going to see your primary care provider, and making sure the primary care provider got the notes, including that the woman was due for an annual mammogram and a clinical breast exam. When that kind of thing goes on, I think patients are more willing to do that kind of transitioning, even though they hate to leave their oncologist. The flip side of that is oncologists don't want the patients to totally leave either, because they get a lot of benefit out of people seeing people who are doing well. But the way we currently see people in follow-up visits is really not patient-centered for them. We squeeze them in between patients who are newly diagnosed or those with metastatic disease, and it's very hard to make that transition between patients. And it's sort of like they get seen for a recurrence and then move on, when we should be thinking about how do we see follow-up patients in a follow-up clinic, whether it's a half a day a week or a day a month or whatever. So I want to challenge you to think about in your practices how you're doing your follow-up visits, and is there a way to reorganize them so that they would be more patient-centered around survivorship needs. Next slide. So in follow-up, the principles of that kind of personalized care is that we really need to think about who will do well at what time period. So somebody low risk may transition out sooner than somebody who's at a higher risk. We need to make sure that we're doing some kind of systematic screening, not just discrete screening, but about long-term and late effects to guide what we're doing with those. And that we may be able to start doing more remote monitoring to help with that, and making sure that they're clear and comfortable with what we're asking them to do as far as self-management is concerned. And then making sure that everybody in the team, the cancer team, the primary care provider, and the patients are all on the same page. And that when we make these kinds of changes in care, that we really get buy-in from stakeholders to make this successful. Next slide. And that's a lot harder than said. So in conclusion, in a summary, basically there's subgroups of survivors who have greater unmet needs than others. And we need to do a better job of screening to identify whether they're physical or psychosocial effects and what we need to address them. And we need to recognize that health promotion is not as well integrated in cancer care as it should be, that we cannot continue to do cancer care the way we were doing it pre-COVID, and that we need to rethink this post-COVID as to how we're going to manage this, that more survivorship research is needed to help prevent or mitigate long-term and late effects, but we also need to do that within different models of care, and that we have to shift the model for how we do follow-up, but we need to base it on the risk for the patient, the collaboration between primary care providers and the cancer team, and thinking about whether This is really the predominant role for APPs, which I personally, as a nurse practitioner and biased, think it is, as well as thinking about how we integrate new roles, possibly like a health coach, to work with people and to support them in their self-management. We need to start thinking about how do we deliver follow-up care that's not just a one-to-one face-to-face visit. And that's going to be the real challenge because we're so busy seeing patients day to day that it's hard to step back and rethink that. And I'm hoping that after listening to this, maybe tomorrow you'll talk to some of your colleagues and start a conversation to think about how we want this to look after COVID and how we might reorganize some of the things that we're doing. Next slide. So here's your last question, or comment. I will explore what type of survivorship services and resources exist at my place of work. Well, I mean, it looks like everybody's answered that pretty quickly. Thank you. And I think I have one last slide. I'm not sure.
All right. So it looks like they got the right answer there.
Let's hope so. Did we have one more slide? Yeah, there we go. And this is why all of this matters is people do not have cancer and be unchanged by that experience. It's a rare person. And so our job is to help them identify and pick up the pieces to make the life after cancer as best as it can be. I think we have time now in the chat to respond to any questions or comments people may have. And I hope that some of you have been posting some.
We do. So, and that'll actually, bear with me for just one moment. That should pop up so that in your poll everywhere, so you can just go ahead and submit those questions and I'll be looking for responses. While we're waiting for those questions to come in, let me ask you, talking about the roadmap for survivorship, what is there an intersect between PRO, between patient-reported outcomes and the survivorship roadmap? And are there strategies that are being used with patient-reported outcomes that can be applied to this roadmap and interacting with the patient during his or her survivorship plan?
It's a great question. I mean, we're trying to implement PROs or patient-reported outcomes during treatment, especially around symptoms. But it certainly has as much application afterwards, although some of the questions are more acute treatment oriented, like for nausea and vomiting, and we probably have to build out more questions for long-term and late effects. The point of PROs is the point that any follow-up visit needs to have some kind of systematic screening that addresses the common issues that survivors experience. And so you can do that disease and treatment oriented and come up with your own checklist, or you can have, there are some survivorship measures. They're more for research than they are for practice. But we need to be more systematically asking questions to screen for those unmet needs.
And then, yeah, what do you feel, and thank you, our audience is sending in questions now, what do you feel are important components of a psychosocial emotional survivorship program?
Well, I think there's differences based on risk. So if you're doing one for a general low-risk population, I think you're normalizing what's going on and that the fact that people may feel anxious or depressed or have fear of recurrence are normal and give them tools that have shown to be effective. But if it's one of those people in that a third that have significant problems with any of those areas, you want to be able to identify them to refer to more intensive interventions, whether it's seeing a therapist or doing a more formalized program for that.
All right, thank you. And what resources can you share for us to explore developing a living with cancer plan or living with cancer clinic?
That's a very good question, and it's a real challenge. So let me I think there are two different things. The living with cancer care plan is what we often refer to as a survivorship care plan. And the research has not supported its effectiveness in patient outcomes, but there's a lot of problems with the outcomes. And even though I've done a lot of that research to say that they don't really work, I still believe in them. I don't know if anybody watches Bill Maher, but he says things like, I don't know this for a fact, but I know this to be true. So I know for a fact that survivorship care plans have not demonstrated improved outcomes, but I know that patients like to get something in writing and that it helps augment what we're teaching. And the reason we should be doing it is from patient education, we know there is evidence when you augment your teaching with them with something in writing, their retention and understanding is better. So I think we need to give them that map. I think we need to do it from time of diagnosis, not just what their treatment plan is, but what their actual diagnosis is and stage, treatment plan, and then revise it when they're finished, and then what their surveillance plan is and what else they can do. The Commission on Cancer dialed down their requirements for that because of all the problems with implementation. We learned a lot about implementation and how not to do it the way we rolled it out with Commission on Cancer originally. But that comes back to how else do we meet the Commission on Cancer standards to meet survivors' needs. That may or may not be a clinic. It may be making available services and knowing what those are and making sure that there's a good fit for when patients have needs that they know what those services are. If you have a high enough volume or you seem to have a lot of patients who would benefit from some of that, then you would have to set that up, and you would probably have to have an APP running it so that you could bill for that and get some income to offset that and figure out when and where and how patients would get referred to that. So every institution may have a different answer for that.
All right, and that's great. And I do apologize because we have several more questions rolling in, and unfortunately we are about out of time for today. I do want to just remind our audience, first off, just say thank you so much to all of you for being here today. Please know how much we appreciate it. And Dr. Mayer, please know how much we appreciate your nationally recognized expertise and leadership in this field. We want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund. We want to thank the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King and Veneranda Obure and John Powell for all of the hard work that they do for each and every one of these lectures.